Good afternoon, nursing students. Next up is Chapter 17, which basically encompasses two disease states, so cardiovascular disease and pulmonary or respiratory diseases. So again, focus on the nutrition therapy for each of these medical conditions as we go through the slides. CVD is a group of diseases and conditions, basically affecting the heart muscle and blood vessels. It encompasses medical conditions that you may have heard before: coronary heart disease, hypertension, peripheral artery disease, heart failure, and also congenital heart disease in infants that are diagnosed typically at birth. Across the board, it's the leading cause of death. And there's different levels of prevention, especially with cardiac disease. We see at the primary level, education, nurses get involved at the community level. So I know that some nurses want to get into ED and critical care, acute care. Also, there are other opportunities in community health. So at the secondary prevention level, the major risk factors of the disease, so there's a diagnosis and we look at the major risk factors to prevent, to decrease the detrimental effects of the disease. And then at the tertiary level, the goal is to minimize further complications of the disorder. The beginning of cardiovascular disease begins with an inflammatory process called atherosclerosis, in which there's damage to the arterial wall. It could lead to CAD, CVA, and peripheral artery disease. Typically begins early in life, and it's important to note the location and the development of atherosclerosis. So for example, in angina or angina pectoris, there are lesions of the coronary arteries. When a patient is diagnosed with an MI, the blood flow to the heart is completely occluded. In CVA, the thrombosis is located in the cerebral artery. And with peripheral artery disease, the occlusion occurs in three places: the abdominal aorta, the iliac, or the femoral arteries. As you recall in Chapter 4, which was fat metabolism, we talked about hypercholesterolemia, high triglycerides, and the altered lipoprotein levels. Any alteration in serum lipids leads to dyslipidemia, which is a risk assessment for coronary artery disease, and that's measured by those lipoprotein levels. Dyslipidemia, we also discussed, is a direct relation of lifestyle changes and as a result of diet. Current research demonstrates that sleep apnea may be the result of being diagnosed with dyslipidemia. The oxygen levels are cut off when a patient is sleeping, so you'll hear them snoring, and as a result, it's triggered by intermittent hypoxemia. The new AHA guidelines were revised in 2017. They now focus on inflammation, and there's less of a focus on total cholesterol levels in the blood. However, we do still look at VLDLs, which is the ugly cholesterol, as I call it, the LDLs, the low density lipoproteins, which is the bad cholesterol, and then the HDLs, high density lipoproteins, which are the good cholesterol. So the VLDLs and the LDLs contain the most amount of cholesterol, and high levels are related to increased risk of CVD, CAD. HDL levels are inverse related. So what that means is higher levels of HDL provides a protective benefit against heart disease. The primary goal is diet therapy to reduce the risk of cardiovascular disease, and we typically look at lowering that LDL cholesterol level. If you're interested in looking at the guidelines, there is a link so you can study it a little further. Elevated triglyceride levels are a class of their own. We typically will see in patients elevated triglyceride levels and not necessarily high cholesterol levels. There are many risk factors that are involved with serum elevated triglyceride levels, including alcohol abuse, cigarette smoking, being overweight, morbid obesity, which ties into the lack of physical exercise, so they're very sedentary. We typically see consumption of sweets, so high consumption of the simple carbs. Other correlations are other medical conditions such as type 2 diabetes, chronic renal failure, and nephrotic syndrome. Certain medications such as corticosteroids, long-term use, protease inhibitors for HIV/AIDS, beta blockers for cardiovascular disease, estrogen for especially women when they're in menopause. Those are risk factors for elevating triglyceride levels as well. There is a genetic component for having high triglyceride levels. So if you're maybe a parent or a sibling has high triglyceride levels, then you may be at risk as well. Having high levels of the low density lipoprotein, the LDL levels, those are very inflammatory in the body. So the HDL, as I mentioned, the higher the level, the better. It provides a protective benefit against CAD. When patients have lower HDL levels, for example, less than 40 milligrams per deciliter in men and less than 50 milligrams per deciliter in women, that is also an additional risk factor for heart disease. I may have mentioned in lecture, there is a gene called the Methuselah gene. So in these small European towns, in Italy, Turkey, Greece, Poland, researchers went to these small towns and started taking blood levels, obviously with informed consent. And it's interesting, they found that some of the residents had this Methuselah gene. So they were levels, the HDL levels were greater than 60 milligrams per deciliter. I mean, some had them in the 70s, 80s, 90s. It was amazing. So these residents have a lower risk factor for heart disease, and they're attributing it to the Mediterranean diet, not having vehicles to walk around. They walk everywhere to go grocery shopping. Looking at nutrition and drug therapies, medical nutrition therapy is the first line of treatment. In Grodner, it's based on the 10 healthy living diet and lifestyle recommendations, which is in table 17.3 in your textbook. So after 3 months, if nutrition therapy is unsuccessful, then the second line of treatment are cholesterol-lowering medications, typically with statins being the top prescribed medication for hyperlipidemia. Definitely know the major medications used to treat high cholesterol and their side effects. We need to talk about grapefruit juice because avoiding grapefruit juice with the statin drugs, so those are the HMG-CoA reductase inhibitors. Those are the medications that I tested when I worked in clinical research. So atorvastatin, lovastatin, simvastatin. What happens is the consumption of grapefruit juice will increase the bioavailability of this medication, so it makes it more potent in the bloodstream. So the cholesterol levels may come down too low, increased risk of that myopathy. And also, if grape juice is consumed with the niacin or nicotinic acid for the treatment of high cholesterol, you could get increased flushing of the face and the extremities. I think just to add that with nutrition therapy, your patient must be motivated to make small diet changes over time. Otherwise, they will not be successful. The physician would recommend drug therapy, but it has to be done in conjunction with nutrition therapy. As a review with dietary fats, the American Heart Association recommends replacing saturated fats with monounsaturated and polyunsaturated fats. That is going to directly decrease that LDL cholesterol level and help to increase the HDL cholesterol levels. So they're recommending more olive oil, canola oil, nuts such as walnuts, almonds, pistachios, and then fish, consuming the fatty fish, which has the oils that are rich in omega-3 fatty acids, which include salmon, mackerel, tuna, and bluefish. That helps reduce inflammation and helps decrease the risk of blood clots. New information regarding the Mediterranean diet. Researchers have found that the components of a Mediterranean diet can reduce the requirement for lipid-lowering drugs, which is really fascinating. So the diet components include, we focus in on the oils that they use. So the olive oil is typically extra virgin olive oil. They consume whole grains and nuts. They use nuts as snacks, and that's all been shown to decrease cardiovascular events. So the Mediterranean diet does include plant-based foods, fresh fruits and vegetables, the dried peas and beans, legumes, lentils. It does also include daily consumption of cheese and yogurt. They don't use a lot of salt. They use a lot of herbs and spices, especially being Italian. We use a lot of like rosemary, oregano, garlic powder. At least twice a week, they consume eggs, fish, poultry. Red wine is always on the table for dinner. And they don't typically consume a lot of red meat. I mean, it's really monthly, and that started during the World War I, where they just really couldn't get red meat in their country. Okay, so for the first part of this chapter, it's basically all about preventing cardiovascular disease. But what if a patient is hospitalized, had an MI? What is the nutrition therapy after a myocardial infarction? We need to know the lifestyle changes for the treatment of MI, which includes going from a clear liquid diet to full liquid, and then progressing to foods of regular consistency. Typically, they're on a low sodium, low cholesterol diet. These patients will typically complain of these foods in the hospital because they demonstrate or remark that they do not have taste, which from a dietitian standpoint, it just makes us realize that they're not compliant at home. It's something that you need to acquire and get used to. Smaller frequent meals are better tolerated because larger meals can increase the oxygen demand by increasing the workload of the heart. So the main purpose, if you will, of medical nutrition therapy for a patient who's recovering from post-MI is to decrease the workload of the heart by decreasing that oxygen demand. And so that's important. Looking at hypertension in the nutrition therapy, there's been a lot of research on high blood pressure. It's typically lifestyle changes, which includes diet, but also exercise. Interestingly, most people think that effective changes for hypertension is decreasing dietary sodium. However, the most effective change is weight loss. So even a loss of 10 pounds, 10 to 15 pounds is extremely effective in decreasing hypertension. Also, any type of movement, we say increase physical activity, but with my patients, if they're older, any type of movement outside, inside, in a mall. Other lifestyle changes would be decreasing alcohol consumption, smoking cessation, decreasing sodium intake, and then more recently with the research when we talked about vitamins and minerals, increasing potassium, magnesium, and calcium intake. So those minerals actually will help to decrease blood pressure in patients that are at risk for heart disease. The U.S. National High Blood Pressure Education Program, they did a lot of research in terms of hypertension, and they recommend lifestyle changes, as does the American Heart Association. So we look at recommending lifestyle changes for mild to moderate hypertension in the duration of 3 to 6 months. We also are recommending DASH diet, which is dietary approaches to stop hypertension. Very effective diet. In 2020, the top 2 diets were Mediterranean diet and the DASH diet. And it wasn't keto or paleo or whatever else they have going on now. The DASH diet is a really great source for anybody. It has the dietary sodium restriction, 2,300 milligrams per day. I haven't seen that strict restriction of 1,500 milligrams per day unless there's like a fluid restriction. It does recommend whole foods, so whole grains, fruits and vegetables, using herbs and spices to flavor the foods instead of sodium, increased dairy products, and then lean types of meat like chicken, fish, and turkey. A patient who goes into CHF, congestive heart failure, make sure you know the medical nutrition therapy. The goal is restricting dietary sodium because we want to decrease the workload of the heart. So for mild to moderate heart failure, it is 3,000 milligrams per day. If it's severe, then we decrease to the 2,000 milligrams per day. So there's going to be a dietary sodium restriction and fluid restriction. Fluid restriction, typically based if a patient is hyponatremic. I have definitely seen the range of a restriction of 1 to 2 liters per day. The second half of this chapter is regarding pulmonary disease. We start out with COPD, which I'm sure you're quite familiar with if you work in the long-term care facilities. So pulmonary function is broken down into 2 categories. COPD, which is chronic, inflammatory, long-term changes to the pulmonary function. It includes chronic bronchitis, asthma, and emphysema. The goal of nutrition therapy is to maintain the respiratory muscle strength and function. We usually see malnutrition, and we want to prevent and correct the malnutrition. Acute changes in pulmonary function would include respiratory distress syndrome, acute respiratory failure, usually in patients that go into shock, sepsis, and are severely injured. So as a whole, we want to decrease that tissue degradation. The tissue is being broken down, it's destroyed. So with that being said, we want to provide additional protein for these patients that are in a hypermetabolic state. With COPD, we usually see malnutrition because of the chronic mouth breathing, the sputum production. Those two can cause an altered sense of taste, so they're not they have a decreased appetite, they're fatigued, they're depressed. And also, these patients are at risk for frequent infections and adverse side effects from the multiple medications that they're on. Nutrition therapy for COPD is to preserve that muscle strength, increase the immune function. We are going to provide adequate but not excessive protein to increase that ventilatory drive. So when a patient's protein needs need to be replenished, we're providing 1.6 to 2.5 grams per kilogram of body weight. When they're in a maintenance state, it goes down to 1.2 to 1.9 grams per kilogram of body weight. So here we don't want to overfeed the patient, and the goal is again to decrease that production of carbon dioxide. Pulmonary function is tricky in that we have to look at components of this respiratory quotient, so RQ. It's a very simple math calculation, so don't let it intimidate you. But the respiratory quotient is the ratio of carbon dioxide produced over the amount of oxygen consumed. So this is important, especially when it comes to carbohydrate consumption in these patients with pulmonary disease. The RQ range is from 0.67 to 1.3. Carb metabolism, so carbs produce the highest amount of carbon dioxide and therefore the highest RQ, so that's not a good thing. Hopefully you'll be able to identify food sources with that high RQ, which are foods that are high in carbohydrates, and the goal is to decrease that RQ, especially in these patients, especially for patients with COPD. So if we look at dietary fat, the RQ is pretty low, 0.7. So what does that mean? It means it produces the least amount of carbon dioxide. So with that being said, especially patients that are intubated, it's very difficult to get them off the vent, wean them off the vent, and by providing a higher dietary fat sources, that helps. You want to substitute dietary fat for dietary carbs. So the goal here is to provide lower amount of carbs and higher fat food sources to decrease the amount of carbon dioxide that's being produced. Acute respiratory failure typically requires mechanical ventilation. Typically, we assess the patient who is now MPO, intubated, and we'll assess them to receive either enteral or parenteral nutrition. Malnutrition is a huge problem. It exists in most cases, which negatively impacts nutrition status. And if that malnutrition is severe, it decreases the probability of weaning that patient off the vent. And the reason is because the chest muscles are just not strong enough to wean from the vent. So the goal of nutrition for acute respiratory failure includes intervention to repair those tissues, give extra nutrients for the hypermetabolic state. High calorie, high protein, moderate to high fat, and if you're giving enteral tube feedings, there are specific formulas. For example, like Pulmicare is the one that I work with for COVID patients in the ICU that are intubated, and on enteral feedings, we'll typically initiate Pulmicare because it is high in calories and protein and has a good amount of fat in it. As I mentioned, patients that have acute respiratory failure tend to require nutrition either enterally or parenterally. So looking at enteral nutrition, the formulas typically provide a high level of calories from fat. They typically have it's a denser formula for patients that require fluid restriction, and to prevent aspiration, we typically do the drip continuously. With parenteral nutrition, we learned that higher levels of glucose concentrations should be avoided because of the RQ level. Carbs provide a high respiratory quotient. In terms of the formulary for fat for parenteral nutrition, we usually provide 1 to 2 grams of lipids per kilogram of body weight. And again, it's infused over 24 hours. So just a note about the high glucose concentrations in TPN, that will increase the CO2 production, and as I mentioned before, it's difficult to wean the patient from the ventilator. Lastly, I want to review CF, cystic fibrosis, know the causes and characteristics. Cystic fibrosis is a recessive trait of the exocrine glands, and there's a lot of mucus production. Characteristics include hypernatremia. We also see high levels of sodium and chloride in the saliva, in the tears, in the sweat. Secretions, over-secretions in the pancreas, in the bile ducts in the liver, and also in the small intestine. Looking at a child that has been diagnosed with CF, typically the physical signs are stunted growth, very thin, they cannot gain weight. If you look at their abdominal area, there's typically a protuberance, lack of subcutaneous fat, especially in the arms and legs, poor muscle tone, pancreatic insufficiency, They get a lot of pulmonary infections, and they typically malabsorb fat-soluble vitamins. Nutrition therapy for cystic fibrosis. We typically base their energy needs on their BMR, what activity level they currently have, based on the pulmonologist's lung function and if they're malabsorbing any fat. We provide enzyme replacement therapies, typically the pancreatic enzymes. Most people think that they have to adjust their dietary salt, and that's not the case. Dietary sodium is usually adequate. A little higher level of fat, 30 to 40% of the total calories. And as I mentioned, there's fat-soluble vitamin malabsorption. So we have to get these special vitamins from the pharmacy. They're called water minuscule form. And so they're a water-soluble kind of like bubble, and inside are the fat-soluble vitamins. And that helps increase the absorption so they don't have fatty acid deficiency. In infants, if they're diagnosed early on, we have to provide those pancreatic enzyme replacements, especially if they're on breast milk formula feeding, or if then they go to cow's milk. And that's typically the only other change in children and adolescents. It's difficult for them to gain weight, so we have to monitor their nutrition status very closely. Typically, they're on a really high calorie, high protein diet. We provide the pancreatic enzymes to support the great growth and help to maintain their nutrition status.